Well, hello, everyone. It's so nice to have everybody here today for a very, very exciting hour where we're going to talk about latest and greatest in the Strong HF study. The Strong HF study has really changed guidelines very quickly, and you would have seen that in the ESC heart failure guidelines update just very recently released. And in the next slide, please. We're so grateful to have with us the PI of Strong HF, Professor Alex Mibaza, who's joined us today. Thank you so much, Alex, to tell us a little bit more about the study and the main messages. Professor Mibaza is Professor of Anesthesiology and Critical Care Medicine in Paris and held the position for a long time. He has been chairman of the department. He's also served on several very, very prominent steering committees, authored many, many papers, including, of course, the ESC guidelines. We also have a real superstar with us in Dr. Jasper Tromp. Now, Assistant Professor Jasper Tromp is with the National University of Singapore Saw Swee Hock School of Public Health. He's co-director of the CVCT Data Management Center at the National Heart Center. Please don't be fooled by his youthful, handsome looks, because he has an experience and a CV that really rivals most people with gray hair, frankly. He's been extremely prolific with many, many talents, but is really, really especially interested and passionate about public health, cardiovascular disease, with a specific focus on heart failure. And he will be telling us some of the latest things we've learned from one of the largest hospitalized heart failure registries in the world, the REPORT HF study. So before we move on rapidly ahead, I think it's really, really important for me to thank Amy Tam, Louise Morgan, the AJ. Truly, none of this would be possible without them. So thank you, Amy, especially, just Amy and Louise for always just putting things together so, so very beautifully. And with that, with the next slide, could I hand it over perhaps to Professor Alex Mibaza, who will start us off with the first talk.
Thank you very, very much, Caroline. It's really my pleasure to share those data with you. Thanks to AHA, Amy, Louise, for organizing this. And I'm really very happy to have a later discussion after Jasper's talk, because there are many things that we can present in data, but other things that needs to be shared, like shared experience on patients, and we may discuss about one or two patients that I had even yesterday, and we used the strong procedure to have them in the right track. Then I'm going to show you the results of heart failure, and also, as you just mentioned, I will talk about the ESC guidelines. Then let's start maybe with the ESC guidelines, and I was really proud to be part of the task force together with Professor Lam. And I think it's important to show you these recommendations because it summarizes the main results of STRONG. Then it's clearly said an intensive strategy of initiation and rapid up-titration of evidence-based treatment before discharge. We'll see this is very important. This is definitely not done today. Then we should initiate all this before discharge and during frequent and careful follow-up visits. This is also needs to be explained, and I will explain how we are going to do this, those follow-up visits. And ESC added, and Caroline and many others voted to have all this done within 6 weeks following heart failure hospitalization. Then the patient comes with acute heart failure. We should start before discharge, and we should finish the optimization of the 4 pillars before the 6 weeks to reduce the risk of heart failure readmission and death. Then everything started with many trials, many surveys showing that the patients that comes to the hospital with an acute heart failure, most of them are still leaving the hospital with congestion. Here is one of the largest ESC database. You see here that at admission, 70% have the phenotype wet and warm, 70% at admission. And you see here at discharge, we still have 1/3 of the patient discharge for whom we wrote in the report that everything is fine, that they are not dyspneic anymore, they can go back home. And we know that at least 30%, 1/3, are still wet and warm, they are still congested. And we know that those patients will go through a phase that is named the vulnerable phase with a high risk of readmission for heart failure and a high rate of death. Then the question that is often raised is how am I going to manage those patients before and even after discharge to prevent this horrible vulnerable phase? In 2021, like Professor Lam and myself and many others, were part of the 2021 recommendation, and we thought that it was needed to give some indications to the physicians when the patient is leaving the hospital after an acute heart failure. We said, please, it is recommended to give evidence-based oral medical treatment before discharge. And we said, we also recommend a visit 1 to 2 weeks after discharge. But in 2021, we really gave those indications without necessarily entering into details. And we thought with Strong that we need to give more granular indications and recipe, I would say. And what is really incredible is that we know that this vulnerable phase kills more patients than many cancers, than patients who are coming out of the acute heart failure episodes can really die with a high risk. But on the other hand, we have the chemotherapy, we have really the treatment that can help minimizing those events. And we have the 4 pillars with a minimal safety concern that can really help those patients. And we know that if you give the 4 pillars that you can find here at the left side of the slides, the 4 pillars, if they give them at a full dose, we know that it's prolonging life by almost close to 10 years. It's really incredible. And really, we have a chemotherapy that works. And we know also that during those 10 years, you can markedly reduce readmission and indeed death. However, although we have clear evidence that we have a treatment that works, we know that all around the world, regardless to the country, very, very few patients get the right treatment and the target dose. Here in one of the trials, you see that only 1% in the United States got the target dose of all those 4 pillar medications. And maybe even more importantly, we need really to push to have those drugs be implemented, because the last therapies we got, ARNI and SGLT2, are rapidly effective. And as you may know, there is this paper published a few years ago showing in patients after an acute heart failure episodes. Here we are talking about weeks, not years or months, weeks. You see here, within few weeks, in the patients who got ARNI, there were less cardiovascular events than patients getting enalapril. SGLT2 also, this paper published last year, Impulse, showing clearly that the patients who got SGLT2 before even being discharged from the hospital, the benefit was greater within a few weeks, few months after discharge. And clearly, we have an increasing number of evidence that the drugs that are given before discharge and in the weeks following acute heart failure are translated in a rapid benefits. Now, coming back to Strong, you may know this result. This result was rather clear in patients who got a high intensity care protocol, meaning that the drugs were giving, and we pushed, we'll enter into details in a minute, we pushed to have the full dose giving within 2 weeks after discharge, half before discharge, and the maximum 2 weeks after discharge. You see when we follow those patients over 180 days, 6 months, there were much less events in the high intensity care arm, meaning less readmission and or death in this high intensity care group. Now, the question that is often raised, but how did you succeed this? Indeed, I always giving the example of a car. If you take a car that has a normal speed, you feel you are safe, and then one day you buy a car that has that is driving at a higher speed. You need to have a safety belt. This is exactly what we did here in Strong. We had a safety procedure. The safety procedure was mainly focused on checking, assessing congestion. Indeed, there is a universal definition now of congestion. There are clinical signs of congestion. Here, fatigue, dyspnea, edema, body weight, and we are also measuring for each visit heart rate and body weight. And again, this is something that you do usually for every visit in patients with an acute heart failure. We didn't do ultrasound. However, we did biology for every visit, measuring natriuretic peptide, hematocrit, potassium, and creatinine. Then basically what we did after discharge, every week for 3 weeks, we were asking the patient to come, and for every visit, we were checking congestion. Now, as I told you, we were successful by improving the primary endpoint because we were successful to implement the drugs. And as you can see here, for the 3 classes of drugs that were tested, we didn't test SGLT2 at that time because it was not recommended. Some patients had it, but not all of them. However, all the patients in the high-intensity care arm were tested for these 3 classes of drug: ARNI, ACE, ARB, beta blocker, and MRA. In blue, you have the usual care, the patients who were treated by a cardiologist in town, and in red, the patients who were in the high-intensity care arm treated by the cardiologist in the hospital. And see here, already at week 2, but clearly at the 3rd month and the 6th month, you see that almost half of the patient had a full dose of ACE, ARB, or ARNI. And you can see that almost half of the patients had a full dose of beta blocker, and more than 80% had a full dose of MRA. Now, this was an incredible positive results that was unexpected. Patients in the high-intensity care arm in the weeks and months following discharge from acute heart failure were much less congested. There was a clear improvement in congestion in patients in the high-intensity care arm, despite, and this is very important, despite a lower dose of diuretics. And it means that for the first time, we have a clear evidence. If you give to your patient the 4 pillars within weeks, within few months, there will be much less congestive, and giving the 4 pillars will prevent congestion to come back. And as you can see here, all the parameters of congestion were much improved and much better in the high-intensity care arm compared to the usual care arm, and even diuretics was at a lower dose. Now, a question that is often raised, but is there a relationship between ejection fraction and the positive effect of the high-intensity care procedure? The answer is no. We included in Strong patients coming with an acute heart failure in the hospital, regardless to ejection fraction, whether ejection fraction was low or high. And as you can see here, the positive and the benefit, the positive effect of high-intensity care arm were seen in all the patients regardless to ejection fraction. And here we have even the patients with a preserved ejection fraction, again, coming with an acute heart failure episodes, they had also a positive and benefit effect. And really it works in all the patients regardless of ejection fraction. It also works in patients regardless to the age. You know that many of us may be scared to give the 4 pillars at the maximum dose in patients who are old. We are wrong, because as you can see here, the high-intensity care arm and procedure are really beneficial regardless to the age. Indeed, there were few higher number of adverse events in the high intensity care arm compared to the usual care arm. However, no difference in serious adverse event or no difference in fatal serious adverse event. Based on those positive results, and also based on the fact that for the first time we could implement 50% or more of the patients with the full medications of the main heart failure therapies, we could have then a large consensus among the task force, among the members, and the recommendation is an intensive strategy of initiation and rapid up-titration of evidence-based treatment before discharge. Half of the dose of all the drugs we're giving before discharge, except SGLT2 that can be given at full dose, but for the 3 other drugs, half of the dose was given before discharge, usually 1 to 2 days before discharge, and during frequent and careful follow-up visits in the first 6 weeks. It's interesting also to mention that the recommendation said that these 3 pillars can be given regardless to ejection fraction, and they also mentioned that glyphosate should be part also of strong procedure. Now, as I said, there are follow-up visits, and it's highly recommended by ESC. During this follow-up visit, as I told you, physicians need to check symptoms and signs of congestion, blood pressure and heart rate, but also because sometimes the signs and symptoms of congestion are missing. However, biology is indicating that there is a worsening in congestion. NT-proBNP should be measured, potassium, and also creatinine for estimated eGFR. This concept of increasing the medications when the patient's not fully treated is also true for patients coming in the outpatient center for worsening heart failure. And this is written in this consensus statement published last year. And you can see here that we should really give the full dose of the 4 pillars of GDMT, and we should really act now for patients with a heart failure and reduced ejection fraction. Then clearly the role of biology is very important. You see here NT-proBNP was used as a safety measure to make sure that NT-proBNP is not increasing. I will give you an example in a minute of 2 patients. And in many other patients, we used potassium and creatinine also to check that the drugs are really safe. Then the NT-proBNP trajectory should be always decreasing. This is what we see here. In this patient here, we have on the y-axis NT-proBNP, and the patients for whom we gave a full medications and NT-proBNP kept decreasing. This is what we named patients for whom we controlled heart failure. However, in some patients, mostly with persistent congestion when they leave, the beta blocker can be associated with an increase in NT-proBNP. And then you see here that with clinical signs or with biological signs, we can keep up titrating the patients. Here are the green lights based on NT-proBNP, heart rate, and blood pressure. Or if we have some red light, we can just postpone by 1 week. And here exactly what I'm going to show you in the 2 next cases. Here you see a patient where everything went well, and the patient had a rapid up titration. The patients came in the hospital with a raise in NT-proBNP indeed, and the patient was treated in the hospital. NT-proBNP went down before discharge, and then we gave half of the 3 main classes of drugs before discharge. We saw the patient at week 2, NT-proBNP kept going down, and then we went to full dose of GDMT. This is really the perfect scenario that we saw in almost 50% of the cases. In some patients, the NT-proBNP went down during the hospitalization. We gave half of the dose of beta blocker ACE MRA. And when we saw the patient at week 2, in fact, we saw NT-proBNP going up at the level or even at a higher level than the level of NT-proBNP at discharge. Then clearly the drug that we are giving, and especially the half of the dose of beta blocker, in patients who are still congestive, induced an increase in NT-proBNP. Then the procedure was very, very easy to follow, very easy. Every time you see NT-proBNP increasing is easy. You just double the dose of diuretics, and you see in this patient it went very well. By doubling the dose of diuretics without touching anything on the doses of GDMT, you see that we kept GDMT at the half of the dose, but by increasing the dose of diuretics, you see that NT-proBNP went down. And then at week 3 or week 4, we could increase all the GMT at full dose, and everything went very well. NT-proBNP kept going down, and the patient at the end was fully treated. Then all this was described in a paper that just came out a few days ago in European Heart Journal, a review where we showed that patients who came with acute heart failure should have a combination of IV therapies during the first 3 days, and then we remove the catheter, and then we give oral therapy, half of the dose before discharge. The patient is discharged, and then we have follow-up visits to go to full therapy with a special attention to female. We can discuss later why. And you see that if the patient has a full therapy, he can start all the exercise, and he will feel much, much better. Thank you very, very much.
Wow. Thank you so much. You know, I can hear you lecture again and again, but I always learn something new. Thank you so much, Professor
Thank
Mibaza.
you.
So much to discuss. I think let's first hear from Assistant Professor Trump, and then we'll have a very robust discussion. Thank you. Over to you.
Thank you very much. Let me share my screen. I think everybody can see my screen now. Great. So I think, thank you so much, Dr. Lam, Dr. Mibaza. Very interesting lecture. I think what Dr. Mibaza's lecture showed very well is, I think, how we can improve. And I think that's one of the things that STRONG-HF provided strong evidence for. And I think some of the data I'm about to show now is particularly in Southeast Asia. Where are we now? So what is our baseline? And how can we then use some of the evidence that Dr. Mibaza showed to further go from there? And that's the data that we've collected and analyzed from Report-HF. Now, maybe as a bit of background, Report-HF was one of the first but truly global acute heart failure registry. We're using a single protocol. This study included 18,553 patients enrolled in 44 countries across 358 sites in 7 world regions, with quite a good representation of Southeast Asia, as you can see here right at the bottom. So the primary aim of Report-HF was to investigate global differences in quality of care and outcomes of these patients with acute heart failure. So it's uniquely designed and suitable to assess how are we doing in terms of medication use at discharge, but also at 6 months. Now, the inclusion criteria you can see here at the bottom were very broad. So like it was any patient deemed to be admitted with acute heart failure as the primary diagnoses, and only those patients were excluded that had a concomitant participation in any clinical trial. Now, this slide shows the median age of patients in reported HF according to a world region. And you can see on the far left that Southeast Asian patients were among the youngest. They were only had a median age of only 61 years. When you compare that to the far right, so Western Europe, it's 75 years. So there's more than a 10-year gap in the median age in the patients that we see in Southeast Asia compared to Western Europe. Now, this slide shows the differences in risk factors. On the far left are our Southeast Asian patients. And in blue, you see the prevalence of hypertension. In orange, the prevalence of diabetes. And in red, the prevalence of ischemic heart disease. And you can see that compared to other regions, our Southeast Asian patients had a relatively low burden of risk factors, especially hypertension was lower than in many of the other regions. IHD was lower, not compared to all regions, but quite a few, so compared to Eastern Europe or North America. But then diabetes was particularly prevalent in the patient population that we see here, as I think many of you see in your clinic. Now, when we then looked at mortality, and that's what this map shows. This map shows the adjusted 1-year post-discharge mortality adjusted for NYHA class. We saw that the patients in Southeast Asia had the highest overall adjusted mortality. So it was as high as 46% in Indonesia, with a 36% crude 1-year mortality, despite, so think again, these patients having a relatively low risk factor burden and being considerably younger. So I think this is quite of an impressive slide, at least to me, working in Southeast Asia, showing that hopefully we can do better for these patients. Now, we then also asked, like, what are the differences in medication use between these patients? And we analyzed these according to country income levels. So on the far left, you see the use of medication, so MRA, beta blockers, and ACE inhibitors in low-income countries. And the majority of these in Report-HF were from Southeast Asia. On the middle, you see this for middle-income countries. And on the right, you see this for high-income countries. And for all these three drug classes, use of these three life-saving medications at discharge was lower than in the low-income regions than in the middle and the high-income regions, especially in Southeast Asia. And what's very important also to note that also, although not shown on this slide, but when we looked at 6 months, there was very little difference in the percentage of patients being on these medications. So that suggests that actually the admission for acute heart failure really is a unique window of opportunity to get these patients on the medications that they should need, because there's very few patients that actually get on it post-discharge. Now, this slide shows the relative dosage of the different drugs. So at the top left, you see this for ACE inhibitors, ARB and ARNIs, the top right for beta blockers, and the bottom for MRAs. So when the color of the country is more red, that means that the relative dosage of these drugs within the countries among patients who are on the drug is relatively lower. And if the country color is more green, you can see that the dosage use is relatively higher. And now when we focus on Southeast Asia, again, you see that many of the countries here are very close to the deep dark red. So even among those patients that are on the drug, the actual dosage that they're receiving for all of these three is actually very low. So we're underdosing patients that are on any of these three drugs. Now, when we look at some of the most important predictors, and this is looking at predictors for being not on any of the three drug classes at 6 months, we saw that those patients without health insurance, twice as likely to not receive the triple therapy. Patients from Southeast Asia and lower and middle income countries, 2.6 times less likely to receive triple therapy. Patients who did not see a healthcare provider after discharge, so this is between discharge and 6 months, were 1.3 times less likely to receive triple therapy, and women in particular were about 1.5 times less likely than men to receive triple therapy. So when you then kind of take the most extremes, namely a woman without health insurance in Southeast Asia, only 1 in 3 at discharge was on triple therapy, compared to a man in Western Europe with health insurance, that 9 out of these 10 men would be on triple therapy at discharge. So that means that particularly women without health insurance in our region are quite a sensitive population that are not on the drugs that they should be ultimately. Now, I pulled out some of the countries, some of the individual countries that, although maybe not entirely representative because we're getting to small sample size, but just to show you of where some of these individual countries are. So this is Vietnam, a mean age of 65, again, 72 in Western Europe, 27% mortality at 1 year versus 19% in Western Europe. 62% of these patients were on MRA, but then generally on lower dosages, 50% on beta blockers, 72% on ACE inhibitors at discharge. And now Indonesia, this was the example that I highlighted previously, a mean age of 55. So these were among our youngest patients that we had, but a 36% 1-year mortality rate versus 19% in patients in Western Europe, and 58% use of MRA, 56% of beta blockers, and 78% of ACE inhibitors. So again, more than half of the patients are on the drug, which I guess is a good thing, but then we're underdosing them, and the mortality rates here still remain very high, 36%. And then the last one, Thailand, in Report-HF, had a mean age of 65 with a 27% mortality rate at 1 year and 19% compared to 19% in Western Europe, where only 27% of these patients were on MRAs, 56% of beta blockers, and 49% on ACE inhibitors and ARB. And again, think that also these percentages did not increase much between discharge and 6 months. So there was relatively no change. Again, emphasizing that this sort of admission is a unique window of opportunity to get these patients on the drugs. So these are the takeaways. So we see that Southeast Asian patients who report HF were a lot younger with a lower risk factor burden, yet a very high mortality. There's an underprescription in patients with heart failure, reduced ejection fraction. That's what I showed in the previous slides for all three drug classes, and often they are in lower dosages. Patients who are less likely to be prescribed medication were more likely women, did not have health insurance, and were not seen by a physician between the discharge and at 6 months. And there's a very limited change in prescription of any of these drugs between discharge and 6 months post-discharge. Thank you very much.
Wow, thank you so much, Dr. Trump. Super excited to answer some of the questions that may arise. So first of all, I'd just really like to, in the next slide, show you a QR code to please scan to submit questions. It's always fun if we take live questions. I'd also like to acknowledge Dr. Larry Allen, who has joined us, and just thank you so much, Larry, for being here as well. Oh, I didn't mean to put you on the spot, but thank you so much, because you know, now we truly look at this, we've got representation from all over the world now. And what we've seen again and again is the poor implementation of guideline-directed medical therapy, although I think all of us really know it works. So can we just have some real brutally honest thoughts on what are the challenges? I mean, what is really the thing limiting it? And, you know, perhaps we can provide perspectives from around the world. Larry, if you don't mind to start, you know, the CHAMP registries and all the get with the guidelines and so on have really inspired us, and we similarly looked in Asia. But what is the crux of it? What's wrong with us?
I mean, I'm a clinician. I spend about half my time taking care of patients with heart failure, and even in a resource-intensive place like the United States, I think there are just a lot of challenges and complexity to getting folks on guideline-directed medical therapies. It, you know, it doesn't mean that it gives us an excuse, but I do think that it's a challenge that we need to rise to, and it requires not just us as individuals doing our jobs. It requires us working together with teams of folks that span transitions of care from inpatient to outpatient setting within systems of healthcare that are supportive, and then with, you know, policy and payment that are supportive of high value therapies. And, you know, it's hard to get all of those things aligned. Like I said, even in the United States, and we certainly have our own challenges. I mean, I would also give credit to Dr. Mabaza. I mean, the conduct of the STRONG trial is quite impressive, because what it does is it actually creates alignment between all of those things, and it gives a path forward for how it can be done. Now, you know, the dissemination and implementation of that kind of work across, you know, large swaths of the world is clearly hard to do, but I will give a ton of credit to the STRONG HF investigators for showing not only that it works and makes people better, but actually showing that, you know, practically it can be done.
Oh, thank you so much. And, you know, that actually brings us to the next question too, that Professor Mibaza, maybe you could respond and then also look at this next question. It really is the thing that comes up every time we talk about STRONG is, how did you do this? Please go ahead.
Yeah, first, I would like to, because since Larry is really known to be a very, very good clinician, I would like really to tell you that this study, which is, as you know, an investigator-initiated study, and again, thanks to Roche, who really was crazy enough to sponsor this study. In fact, the reason why we did this trial is because I had few patients, old lady. I remember very clearly this old lady, maybe 75 years old, who kept coming back every 3 days with a new pulmonary edema again and again. And for acute HFpEF, as you know, it's worse because there is nothing in the literature for HFpEF. And at some stage, I said to my fellows, I said, no. There's no way this we are going to have her again for the fourth or the fifth time. No way. I mean, it's horrible. And then we start to give the GDMT, and it worked. And then the next patient we did it, and it worked as well. And then we thought it's incredible. In fact, all what we learned in medical school, which is going slowly, try to avoid combining, etc., is maybe true for some patients, maybe the more advanced heart failure, but in patients for whom it is like the first or second episode, apparently we can do it safely. And now, how would you implement strong heart failure protocol in the real world? What I can tell you is that the investigators really have to be thanked because they're really brave. But we had this reason why I entered a little bit into details. We had really a strict protocol, but the strict protocol, it's not rocket science. It's really not rocket science. It's just before discharge, if the patient is at the hospital, then really the safest environment. Before being discharged for let's say 48 hours before being discharged, just already give full dose of SGLT2 and half dose of the three others. And you're in the hospital. And if something will happen in the first 48 hours, you will see it. And then when the patient is discharged, we ask them to come again. Now because it was really a challenging protocol and we were scared by safety, we asked the patient to come every week in the first weeks. But now we are working with few centers in the US, in Europe, in Africa, by the way, where we are doing week 2, week 4, week 6. Basically, the idea is we can really reduce the visits to go back to 3. However, for every visit, we need to be really obsessive and do the comprehensive clinical exam and also biology and NT-proBNP. We have a paper that came out just a few days ago showing that in 30% of the patient, NT-proBNP went up, which again is normal because we gave beta blocker in patients who are still congestive, and we just had to increase double the dose of diuretics, and it went very well. And in fact, in those centers, they told me, but Alex, how are we going to put them in the outpatient center? And in fact, we looked in the patients that are seeing in their outpatient center, and we saw many patients who do not necessarily have to be seen every 3 months. And then we said, okay, why don't we postpone to 4 months or 5 months? However, we said to the outpatient center that every patient coming out from an acute heart failure is really priority number 1. And in fact, you see that in large centers, even in large centers, is maximum 1 patient a week or 2 patients a week, meaning 1 patient to add in the list every 2 or 3 days. And then if there is really a will to do it, it's really easy to do.
Wow, I really appreciate the way you broke that down. Sorry, was Amy or Louise trying to say anything about Slido, or will we be able to see if the audience has any questions or more
Yes,
than
it will be after these 2 questions.
Oh, there will be more? Okay.
Yeah.
Good. I'm really looking
We better
forward to
hurry
that.
up, Caroline.
Yeah. So actually, just to bring Jasper into the conversation too, I was of course very struck by the situation in Southeast Asia that always seems just worse. Younger patients, yet worse outcomes. Add to it that it's the women who seem to get the worst treated. Oh, it just I just love first for your thoughts on, what do you think we can do about it, and perhaps maybe even what we're doing about it with the AHA and HF Asia.
Yeah, no, thanks. I think that's I think that at the higher level, I guess there's the structural issues with funding, and I think in the way we fund the healthcare systems in across Asia is very different, and makes it also difficult to follow up with patients, I think. But I think with together with with the Guidelines Asia, I think where we're trying to educate and help physicians improve sort of care and also keeping track of how you treat them over time, I think shows already like early improvements in getting patients on GDMT. And I mean, it's now rolled out in, I think, 5 countries right now, right? So I mean, the early results seem quite successful, but I think that to me, that shows that also partially creating more awareness and then finding a champion within your own local hospital that's willing to be that person to, to sort of create that awareness within your hospital, potentially with, implementing strong HF or equivalent, I think, is an approach that could work.
Thanks so much. I really do think sometimes we do need a report card. Now, we all hate that idea of being watched and sort of assessed, but maybe we can see it as looking into a mirror, just to objectively reflect, are we really doing our best? I also frankly think a little bit of competition, because now we're all in Asia, and we can't sort of say, and I'm going to the next question, Asians are too small, too old, BP is too low, I don't know, because
Caroline, in that
Asian
topic,
center is getting better outcomes, you know what I mean, or higher doses. Yes, Alex, please.
Yeah, many people are saying, I mean, to explain the results that Jasper is showing, and we have the same in North Africa and Africa. I heard in large meetings some people saying, but Alex, we heard that the heart failure therapy does not work as efficiently in men and in women, and this is totally wrong. This is totally wrong. We showed in STRONG, it worked as well. And then I heard others saying, oh, but anti-proBNP is not reacting similar way in men and women. It's totally wrong. This is totally wrong. We should have a procedure, follow the procedure, and it works as beautifully. And there was a paper with Yelena Sebut-Kinier on STRONG. It is highly, highly efficient.
Thank you so much for emphasizing that. And then, Alex, you kind of left us a little hook when you were speaking. You said, especially focus on the women, and I will get back to that. And then you never, so why?
Yeah.
Why did you say that?
In fact, because we have this paper with whom you are co-author, by the way, in European Heart Journal a few years ago, where we were lucky enough to have data going from Japan to the United States. And when we put all those data together, and even when we looked by region, we were surprised to see, exactly like Jasper was mentioning, women were less treated than men. However, women had a lower mortality than men. And this was really a big surprise for us. And this comes back to what Jasper was saying. We should really push for women and for men those medications. But here, now we kept looking on a few other countries, like in North Africa. Not only, unfortunately, women, not only they are less well treated, but here we have the side effect, mortality is higher. Then really it's exactly what you mentioned, what Jasper mentioned. There is no way we should keep the woman being less treated, because at the end of the day, in many countries, mortality is higher. Then really we should push all the fires, and the drugs are working as efficiently in women than in men.
Yes, in both men and women, in both the older and oldest, it shows, right? That's what you showed us in STRONG.
Absolutely.
I think we just really need to examine why we're making excuses based on this. Let's remember that the trials that included Asians never said that there was a lower target dose or lower initiating dose for Asians compared to other ethnicities. It was never that way. And guess what? In those trials, Asians tolerated the same way as everyone else in the trial. So I mean, I'm humbled because I practice here, and we always go by eminence-based medicine first, isn't it? Rather than evidence, we follow the great professor, and the great professor says start at, it's not even half, it's not even quarter. I think we start at like the smallest dose, and we have it again. That's how we start medications here in Asia usually. And I think maybe it's just time to sort of say, you know, why are we doing this? But the guardrails that you talked about is also very important. I mean, we shouldn't just be shooting without looking where we're aiming also, right? The guardrails of assessing the physiological response and the safety guards are also important. Thank you so much for that. Do we have some questions? Oh, how nice. All right. Well, we can see them. There's one right on top. Most patients admitted with acute decompensated heart failure are often labeled as having acute coronary syndrome as a precipitant. And the data on the use of ARNI and SGLT2 are poor in this area. Okay. How do we go about this? Does anyone want to?
Yeah, I can maybe take a
Yeah.
little bit this over. In fact, let's be away from the ACS that just happened a few days ago and patients doing an acute heart failure related to an acute ACS. But let's say if the ACS happened 3 months, 6 months, and then we are more on the comorbidity or more on the cause, but for a long time. In STRONG, and this is paper of Ovidio Chioncel, we clearly showed that regardless to the comorbidity, regardless to the effect that the initial cause of heart failure is ACS or other cause, the high intensity care procedure, again, before and after discharge from an acute heart failure was shown benefits.
Yeah.
I mean, I think I'd
Yeah.
also add that Paradise was negative. So there's some question about the benefit of an ARNI over an ACE in acute MI with a drop in ejection fraction. But I think there's very strong data that patients who have a large, infarct, who then have symptomatic heart failure with a significantly reduced ejection fraction actually do benefit from neurohormonal antagonist therapy. So I still think the concept of getting people on an MRA based on the EPHASIS data and then treating them with ACE and ARB if they have low ejection fraction still holds very true. So I don't think these other later trials that don't show a large incremental benefit of the newer drugs argue against good therapy. And then, as was mentioned, if somebody has ischemic heart disease months down the road, those people absolutely qualify for 4-pillar therapy.
Absolutely. And again,
Yeah.
if people have any doubt, they can measure natriuretic peptide. And if they're high, the diagnosis is done, and then the patient should enter in the tunnel of heart failure therapy.
Yeah. And if I may add, I mean, many of the trials in the sort of subacute heart failure, let's say in the SGLT2 realm, certainly included patients who had ischemic heart disease. Now, note, we're not, of course, talking about pure primary AMI without manifest heart failure. We're talking about a heart failure hospitalization that may have some ischemic elements or may have underlying ischemic heart disease. And certainly the SGLT2 inhibitors were found to be effective in all these subgroups and safe. I don't know whether what we're worrying about is safety or efficacy here. Of course, though, the jury is still out with the SGLT2 inhibitors, with the big AMI trials coming out soon. But I think we're pretty unanimous in saying we would still get on the 4 pillars if the primary admission is heart failure and if it's safe. In the Asia setting, it's very tough to implement the intensive arm of STRONG HF. We may have to look at alternative methods.
Why is it tough? Because people are not coming to the hospital? Let's say I understand that maybe it's difficult for people to come to the hospital. We are working on alternative methods to try to reduce the face-to-face visits between cardiologist, physician, and patients. There are few trials that are starting a little bit all around the world with telemonitoring. I personally did a study in Tunisia combining half of the visits done by a cardiologist or physician and half done by nurses at home. It works very, very well. The study is named CD. There are other ways also to look on congestion. There is a study named CUMIN with Jasper Caroline that also should, I hope, come out soon, again, at home by a nurse. Then again, we come back to the will. If clearly it's like a cancer, if you have a patient with cancer And there is no discussion. You should give a full therapy, a full chemotherapy to have the patient being saved. You will find ways to go around.
Thanks, Alex. And, just recognizing from many people who've also liked this comment that, yes, of course, there are barriers. We're not saying there aren't. And many a time you do have to work with your institution and fight for having the system to change. But surely we have to get better. We have to get better. And thank goodness, one of the good things about COVID is it taught us that many things can be done safely remotely. So we can get creative.
Yeah.
Yeah. Asia has one of the most robust sort of mobile care systems, in countries like Indonesia, they're huge mobile care companies and so on. I mean, how about partnering people like that,
Sure.
for example? I mean, we need to be more creative, I think.
And
Now,
it's an
beta blocker.
incredible opportunity to do research. Yeah, I mean, I'm sure you are in contact with them, and there's an incredible opportunity to do new techniques, new ideas. Yeah, and I'm sure the whole world will love it.
Yeah. We have 5 minutes more, but I'm anxious to get to these questions. They're very, very good. Oh, it just changed. But it's about the hypotension in Southeast Asia. And, we do always feel that we have a pretty remarkable risk of hypotension when we try to up-titrate things like ARNIs. The question is that the dose-related increase in efficacy seems most obvious for beta blockers. How much should we push for ARNI? Interesting question. I know where it's coming from. Alex, you are unmuted. I'm not sure if you have immediate comments or.
Just just maybe a small comment. This comes from the paper that just came out in Journal of Cardiac Failure from Still Strong and Marco Metra, the senior author, and it was a late-breaking trial at HFSA. And we showed that, in fact, hypotension and bradycardia were the least side effect we saw on Strong. And that the more frequent side effect was, again, an increase in NT-proBNP, meaning an increase in congestion in patients who came out from acute heart failure episode, and hyperkalemia. And by the way, we saw that even in patients with a potassium higher than 5 millimoles, high-intensity care arm was still associated with benefits. And really, you should not be scared by 5.1, 5.2. For hypotension, when the blood pressure goes down, again, it's less frequent than increase in NT-proBNP or increase in potassium. And indeed, what we did in our procedure is to say, if really we have this hypotension after half of the dose, we are going, and if it is symptomatic, we are not going to try to push further. We will push further the other drugs. In our analysis, hypotension happened more often in patients with advanced heart failure than really patients in the beginning of the journey of heart failure. Then indeed, we should pay attention on the patients in the last phase, I would say, of the journey of heart failure. And if they have a hypotension, it means that maybe we are at the maximum of what we can give. But again, Strong and the concept of Strong and the concept of giving the 4 pillars, we should think more and more about them in the early phase of the heart failure journey.
Yeah, thank you so much, Alex. Oh, we're running out of time, but I couldn't agree more and would like to. Of course, it's true, even in the subacute heart failure ARNI trials, yes, there's a little bit more risk of hypotension. So we acknowledge that, but no one's asking you to go to max dose straight away. It's just we cannot get otherwise complacent or to otherwise say, well, we know it's going to be an issue and therefore we don't try. I think that's the main thing. And I think many a time our patients actually surprise us. We start with the half dose. And interestingly, as they improve, they actually tolerate higher doses. I think the main thing is, be wise in not, of course, making sure that it's not a patient that's dehydrated and already, symptomatically hypotensive, and then we started. Nobody's saying to do that. And also, let's be careful not to give up too quickly. In other words, to already label a patient very early to say, oh, it's just intolerant. And then we write it down, intolerant. That's like sentencing the patient to never get another challenge of a higher dose of ARNI later and so on. I think, there are a lot of nuances to that, and I really do appreciate the question. In a last minute, I think it's going to be very, very difficult to address the whole question of HFpEF, although I'm so happy to see it asked, because I do agree that was one of the most interesting parts of STRONG, that even patients with HFpEF seem to be benefiting from rapid up-titration of triple therapy. Alex is kind of going, no, I could have told you that long ago, because acute heart failure is a neurohormonal storm, right?
Exactly. I can give you a very short answer. The only thing that STRONG showed, the only thing is within 6 months after an acute heart failure episodes, if you give the 4 pillars, it saves lives and it reduces rehospitalization. After 6 months, 6 months and 1 day, I don't know, and it has to be proven. But clearly, exactly like you said, in the first 6 months, there is a big storm, neuroendocrine stimulation. Patients who are again and again trying to do again congestion have more congestion coming back, and here you can cut it and avoid rehospitalization. After 6 months, I don't know.
Oh, that's fair. Well, I would also then extend it in the chronic HFpEF trial. Let's notice that at baseline, most HFpEF patients come in with the triple therapy, either for one indication or another, or blood pressure.
Exactly.
So
exactly.
Well,
Exactly.
let's just make sure we
Probably.
add the SGLT2 inhibitor as well when it comes to HFpEF.
For sure. For sure.
Oh my goodness. So thank you so much, everyone, for being here with us today at inconvenient times, and especially again to the AHA team, led by especially Amy, for working so hard to prepare everything. Thank you, audience, for your questions. I really hope you've enjoyed this. I've certainly learned so much, and I'm very, very grateful to the faculty. Thank you very much.